Oral cancer, a clinical diagnosis. Terminologies. Neoplasm, an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissue. Carcinoma, malignant tumors arising from dysplastic epithelium with the involvement of underlying connective tissue. Next is the risk factors involved in the oral cancer include genetic factors, viral infections, fungal infections, bacterial infections, tobacco, both in the smoking form and in the smokeless form, poor oral hygiene, potentially malignant disorders such as speckled leukoplakia, oral submucous fibrosis, discoid lupus erythematosus, erosive type of lichen planus, and proliferative verrucous leukoplakia. Also, the deficiencies of vitamin A, E, C, or trace elements, and immune defects. Next, moving on to the pathogenesis. Now let's know how a normal cell transforms into a cancerous cell. Initially, on the exposure of normal cell to a carcinogen results in overexpression of tumor necrosis factor alpha. This causes cellular hyperplasia. The overexpression of epidermal growth factor over the hyperplastic cells results in dysplasia, which is the key factor in the malignant transformation. Following which, the mutation of Kirsten-Rat sarcoma viral oncogene and inactivation of adenomatous polyposis collagen will lead to the transformation of dysplastic cells into carcinoma in situ, which is the earliest stage of oral cancer, limited to the epithelium of the oral mucosa that have not yet invaded the deeper tissues. Inactivation of tumor suppressor p53 gene will cause the invasion of cancerous cells into the connective tissue, breaching the basement membrane. After which, the overexpression of myelocytomatosis oncogene and downregulation of epithelial cadherin will cause metastasis of cancer to distant sites. Next is the clinical features of oral cancer. The common location of oral cancer is buccal mucosa and commissural mucosa in the Indian population, whereas it is the floor of the mouth in Western countries. During the initial stages, it will be an asymptomatic erythroleucoplastic lesion. In the advanced stages, there will be presence of ulceration, lumps, induration, nodularity, and fixation to the underlying tissues. The other manifestations are also included. Differential diagnosis of oral cancer: deep fungal infections, tuberculous ulcer, eosinophilic granuloma or traumatic ulcerative granuloma. Clinical method of detection. First is the conventional oral examination, which is the standard method of screening. Next is the toluidine blue staining, which stains the tumor cells. Tumor cells create intercellular space that allows the penetration and retention of dye. Indications: choosing the biopsy sites facilitates the decision to perform biopsy. Visual inspection by Lugol's iodine, which tests negative when the oral cavity is homogeneously stained and tests positive with the well delineated non-staining areas. Next is the rose Bengal staining, used to delineate the extent of oral epithelial dysplasia. Pink color indicates positive staining. Next is the Visilight, which works under the principle of chemiluminescence, diagnostic tool devised for early detection of cancer, where the normal tissues appear dark whereas the abnormal tissues appears white. Next is the Well scope with a high sensitivity of 98%. Healthy tissues appears as bright apple green and suspicious regions appear dark. Conclusion: the importance of early diagnosis of oral cancer improves survival rate, reduces treatment intensity, and enhances the quality of life. When diagnosed early, oral cancer can often be managed with localized treatments that minimizes damage to surrounding tissues, preserving essential functions like speech, swallowing, and facial integrity.